All right, we're going to move on to chapter 7. And so we've already talked a little bit about bone structure in our lab, but now we're going to be talking about bone functions and calcium regulation. And this is going to involve some hormones, so we'll talk a little bit about hormones and what they are, but we'll learn a lot more about them in 169. So what are the components of the skeletal system? And some of this is a review because we did talk about this in lab, but as I said, it's good for you guys to hear it twice. So the bones are going to be the main component of the skeleton, right? So we talked a little bit about the anatomy of the bones, gross and microscopic anatomy of the bones in lab. Remember that cartilage is also part of the skeletal system, specifically hyaline cartilage and fibrocartilage. We find hyaline cartilage on the ends of the articular cartilage as well as in the growth plates. Hyaline cartilage is the model from which our long bones are going to develop. And then fibrocartilage is going to be found as part of joints, part of the fibroses, so our symphyses. So it's going to be our pelvic symphysis, our meniscus and our knee, as well as our intervertebral discs are going to be made of fibrocartilage. Ligaments are going to be these strips of dense regular connective tissue, and these dense regular connective tissue strips are going to connect bone to bone. So ligaments connect like to like, so they connect bone to bone. And then we have some other connective tissue, specifically the bone marrow is made of reticular connective tissue. That's going to be important for some of the functions of bones. So bones are the primary organs of the skeletal system. They make up the rigid framework of the body, and they're really important for movement as well as protection and structure, and they have many other functions. As we said before, cartilage is semi-rigid connective tissue. It is more flexible than bone, and the two types are hyaline cartilage and fibrocartilage. Ligaments connect bone to bone, and tendons connect muscle to bone. So tendons are also made of dense regular connective tissue, but they're connecting muscle to bone rather than bone to bone. So remember, ligaments connect like to like, tendons, so bone to bone, tendons connect muscle to bone. And we'll talk a little bit more about tendons in the muscular system. So what are the general functions of bone? Bones are really important for support and protection. So our long bones are going to be a little bit more for levers for movement, but support and protection is going to be a lot of our, so long bones help support us, obviously, and a lot of flat bones are going to be important for protection. So your flat bones of your skull are going to help protect your brain. The sternum is going to help protect the heart, and also your irregular bones, like your vertebrae, which are irregular bones, are going to surround your spinal cord and protect your spinal cord. As we said, long bones especially are important. They act as levers to help with movement, and we'll talk a little bit more about that in the joints chapter, chapter 9. And then hemopoiesis. So hemopoiesis or hematopoiesis is the production of blood cells. And this is going to happen in the red bone marrow connective tissue. And this is found within the marrow cavities of our long bones as well as within the little spaces in the spongy bones. And the distribution of red versus yellow bone marrow is going to differ in adults versus children, with children having a lot more red bone marrow and adults having more yellow bone marrow. Another thing that bones do is they store and regulate minerals and energy. So we said that we're going to talk a little bit about calcium regulation today, but that's not the only mineral they store. They also store phosphorus, and so phosphate, and they store fat in the yellow bone marrow. As we said, adults have a greater proportion of yellow bone marrow, and this is going to be storing some good energy or fat. If you've ever watched one of those like nature documentaries where you see the lions like breaking the bones and eating the marrow out, well, that's a really good source of energy. All right, so I want to talk a little bit about bone marrow. Bone marrow is that soft connective tissue of bone. It's going to fill the marrow cavities in the long bones, but it's also going to go fill in the little spaces in spongy bone. And we have two different sort of types of bone marrow, red bone marrow and yellow bone marrow, and they're named because of their color. Makes sense. Red bone marrow is also called myeloid tissue. This is going to be hemopoietic or blood cell forming. It's made of reticular connective tissue. So remember that reticular connective tissue often has a lot of blood cells and white blood cells and red blood cells in it. It has those reticular fibers in it. It's also going to have a lot of immature blood cells in it, right? Because the blood cells are developing in this red bone marrow. And there is a little bit of fat for storage. In children, we have a lot of red bone marrow. It's located in both the spongy bone as well as the medullary cavity of the long bones. You know, they're growing and they need a lot of blood cells. And so we've got to make all these blood cells for them. In adults, it's located only in selected areas of the axial skeleton. So the axial skeleton is going to consist of everything in like the main axis of the body, so the head, the neck, and the trunk. Whereas the appendicular skeleton is going to be made up of the appendages. And we're going to talk a lot about the different types, the different parts of the skeleton in Chapter 8, so in the next couple of labs. So in adults, our red bone marrow is going to be found within the flat bones in the skull, within the irregular bones of the vertebrae, within parts of the rib, the sternum, so these are the axial parts, the os coxae, which is individual pelvic bones, and then the proximal epiphysis, so the top part of your humerus as well as your femur. And so here is a picture of everything here in red. This is where adults have red bone marrow. So within the vertebrae, the axial skeleton here, the pelvis, as well as the proximal epiphysis of the humerus, as well as the proximal epiphysis of the femur. And we can see in this picture here, the red bone marrow is going to be this outer stuff. It's mostly that myeloid blood cell forming tissue, and we have a little bit of yellow bone marrow in the middle that is mostly filled with adipose connective tissue, and that's going to be important for storing energy. And so the yellow bone marrow is actually a product of red bone marrow degeneration as children mature. So we don't need as much blood cell forming tissues, and it's going to kind of degenerate, and that myeloid tissue is replaced by a fatty substance and some adipose tissue there, and where we've got a good area for fat storage. And so this may be able to convert back to red bone marrow if it's really needed. So anemia is a term for, basically it means you don't have enough red blood cells. And so if we don't have enough red blood cells, well, maybe we need more red bone marrow to make more. So during a really severe anemia where we really don't have enough blood cells over a long period of time, this would be a chronic change. It's not something that will happen in a day or two, or if you're bleeding out. But over a long period of time, then we may have some yellow bone marrow that converts back to red bone marrow to help produce additional red blood cells. But as we said, this doesn't happen quickly. So when we get to the chapter on blood, so chapter 18 in 169, we'll talk a lot more about the different hormones and everything that are involved and how exactly the blood cells are made. But know that they are made in the bone marrow, the red bone marrow specifically. And that's kind of as far as we're going to go in this chapter. And we'll get into the details in 169. So clinically, you probably think of the bone marrow when you hear about bone marrow transplant. So a lot of people, if they have some sort of malignancy or cancer in the blood-forming cells, they might have abnormally functioning bone marrow. So their bone marrow isn't working properly, and it's just making cancerous cells, maybe. And so what happens is that abnormal bone marrow is going to be destroyed by radiation or chemo. And so they're not going to have any bone marrow for a little while. And then they're going to have to harvest cells from a donor. And so they're going to take the cells from the donor, and in order to harvest it from the donor, they're going to have to go here to like the pelvis. One of these areas that has a big amount of this red bone marrow, because they can't get it in an adult. They can't really get it from anywhere else because you have yellow bone marrow in your big marrow cavities. So they're going to have to take it from like the pelvis or something. So we're taking some bone marrow from a donor, and it has to be matched appropriately, right? So we have to make sure that they would match. And then those cells are going to be injected into the bloodstream of the recipient. And they're going to migrate to the normal locations for bone marrow and then hopefully start, colonizing that area, and then we're going to make new bone marrow. And this bone marrow is then hopefully going to be healthy bone marrow. If it was healthy bone marrow taken from the recipient, then it can start producing healthy red blood cells or white blood cells, whatever the problem was. All the healthy cells, because the bone marrow should produce all of them. All right, so now we're going to move on to, we talked about our bone marrow a little bit. We mentioned the types of cartilage and tendons and ligaments. Now we're going to move to bone itself. So we looked at bone under the microscope in lab, and we kind of looked at the different pieces like the canaliculi and the lamellae. And we talked a little bit about the osteocytes and the osteoblasts and the osteoclasts and the osteoprogenitor cells and where we find them. But now we're going to kind of talk a little bit about what they do and the differences between these different blood cells. So bone is composed, it's a connective tissue, so it's composed of cells and extracellular matrix. Remember that extracellular matrix is going to be composed of protein fibers and ground substance. So what are the cells of bones made of? So let's look. We have 4 different types of cells found in bone connective tissue. These are those specialized cells. And remember, we said osteocytes. Anything that starts with the prefix osteo, we think bone. So we have osteoprogenitor cells, osteoblasts, osteocytes, and osteoclasts, and they all have different jobs. So the first one we'll talk about is the osteoprogenitor cell. This is one of those unipotent stem cells that was derived from the mesenchyme. And so this is a stem cell that can just become an osteoblast. So it can keep dividing, and as it divides, one of them will stay as an osteoprogenitor cell, one daughter cell. The other daughter cell will become an osteoblast. Then that osteoprogenitor cell can divide again. One stays as an osteoprogenitor cell, the other one becomes an osteoblast. So then we have, a supply of osteoblasts if we need them. And those osteoblasts are then going to do their job, which is creating the matrix. And these osteoprogenitor cells are going to be found, remember, in the cellular layer of the periosteum and the endosteum. So on the outside or the inside of the bone. Now, once the osteoprogenitor cells divide, we said one of them stays as an osteoprogenitor cell to make more cells later, and the other one is going to turn into an osteoblast. The osteoblasts have a special job, and we said anything that ends in the term blast is going to be something that's building the matrix. So these osteoblasts are going to synthesize, they're going to make, and they're going to secrete what's called osteoid. Osteoid is like it's the organic component of bone, or pre-bone. It's the semi-solid organic form of bone matrix. So this is the bone before it becomes calcified and before it becomes hard. So this osteoid is kind of like the soft stuff that is laid down by the osteoblast, and eventually it's going to calcify. And we'll talk a little bit about how that happens. So eventually it's going to calcify. When the osteoblast, they're going to secrete all this stuff around them. As we said, they kind of paint themselves into a corner. So they're going to secrete all the osteoid around them, and it started out semi-solid, and they kind of secreted it around them. And then it's eventually going to calcify, and it's going to trap them within the matrix into their lacunae. Once they become trapped within the matrix and they're kind of living in the lacunae, remember, and they send those little projections, those processes out in order to maintain the matrix, we call this an osteocyte. So the osteocyte is a mature bone cell that's derived from the osteoblast. They have their little processes that are going out, reaching through those canaliculi, and they detect stress on the bone, and they can also trigger new bone formation. So they're going to help maintain the matrix, and if it starts there's too much stress, it's going to tell the osteoblast to create some more and make the bone stronger. So those 3 are going to be, we have osteoprogenitor cells become an osteoblast, and then it becomes an osteocyte. So these are kind of in a progression. So we start with the younger osteoprogenitor cell, then we go to the osteoblasts, which are the secreting cells, the osteoid secreting cells, and finally to the mature osteocyte. And those are all related to each other. They're like a family. Whereas our osteoclast is going to be a little bit separate. It does not form from this same line of cells. Osteoclasts are going to actually come from the bone marrow, so fused bone marrow cells. And so they're large and they're multinuclear. So if we had multiple cells fused together, right, so they all had their own nucleus, and now it has multiple nuclei in here. It looks a little bit like a monster with these tentacles in it here. So the osteoclast is this scary, tentacle monster looking thing that actually is going to be absorbing the bone and breaking the bone down. And it's going to do this using its hydrolytic enzymes from its lysosomes, right? So it's going to like spit out this acidic, spit and absorb some of the bone. So these are going to be, they have a ruffled border. That's what looks a little like the tentacles. It increases surface area that's exposed to the bone. And it's located within or next to what's called a depression or a pit in the bone surface called a resorption lacunae. And they're involved in bone resorption. So we can see here, this guy, it's spitting out this, the hydrolytic enzymes to help break down the bone matrix and to break down break down and digest the organic components of the bone matrix. And so it's going to be making this little pit. So as it sits there, it's kind of dissolving the bone underneath it, and it's making the resorption lacunae. And so osteoblasts build the bone. Osteoclasts are going to reabsorb the bone. So bone matrix, osteoblast that's building this bone matrix has both organic and inorganic components. Remember, organic components means that they have both carbon and hydrogen in them and are organic molecules are going to be things like proteins. And so the organic components are going to be secreted. It's called osteoid, and this is produced by the osteoblast. And they contain mostly collagen protein. So remember how that collagen, in each successive layer of the lamellae, our collagen is going to be oriented in a different direction to make sure that bone is strong in all directions. It also contains that semi-solid ground substance of proteoglycans and glycoproteins, right? So that's the protein with a carbohydrate attached. And we talked a little bit about proteoglycans when we mentioned the different things that go into ground substance. And so this collagen and, proteoglycans and glycoproteins, all of it is sort of semi-solid. It's the organic part made by the osteoblasts, and it gives the bone the tensile strength, right? So it resists stretching. So just think of collagen. Collagen is kind of like a rope where it's flexible, at least a little bit, but it doesn't really stretch. And so this is it's strong and flexible, but it doesn't really stretch, just like the collagen. Now the inorganic components, this is the part that happens later. So the osteoblast secretes the organic components first and kind of lays it down as bone. And then after that, we're going to have the inorganic components. So this is the mineral components. The salt components are going to then be laid down on top of it, and they're going to crystallize and calcify. And so it's made of salt crystals, calcium phosphate, and that's going to interact with calcium hydroxide and form these hydroxyapatite crystals. So you're not going to need to memorize this chemical equation, but do know the term hydroxyapatite. So depending on where you live and what other substances you have in your body, we can incorporate other substances into these crystals too, so like other minerals, calcium carbonate, sodium, magnesium, sulfate, and fluoride. So these hydroxyapatite crystals here, so mostly made of calcium and phosphate, are going to deposit around the collagen fibers. And so this is going to harden the matrix. It's going to calcify the matrix, and it accounts for the rigidity of the bone. So it makes the bones hard. So they're already a little bit strong and flexible, but now they're harder too. And remember that the bones are an important storage area for calcium as well as phosphate. So calcium and phosphate are going to be stored in the bones in the form of this hydroxyapatite crystals. And these hydroxyapatite crystals are going to be deposited around the collagen fibers, which is part of that osteoid, and it's going to make the bone hard and strong and rigid. So as we said, bone formation begins with the secretion of osteoids. So which cells secrete the osteoid? The osteoblast. Osteoblasts secrete the osteoid. Once the osteoid is laid down, remember that contains those collagen fibers in it, calcification occurs. And so that's when we have the deposition of the hydroxyapatite crystals. So the calcium and phosphate ions precipitate out and form crystals around those collagen fibers. So this whole process requires a couple of important minerals and vitamins. So vitamin D is important in your diet because it enhances calcium absorption from the GI tract. Remember, vitamin D, we talked about this in our skin lecture. And so vitamin D can be made in the keratinocytes when exposed to UV light. So it starts as cholecalciferol and it becomes calcidiol and then calcitriol. We'll talk about that in just a little bit. Vitamin C is another important vitamin. And vitamin C is required for collagen formation. And remember, we mentioned this when we talked about collagen. We said that a lack of vitamin C is going to cause scurvy, right? So thinking about the pirates and the lemons and things. So we need to make sure to eat lots of fruits and vegetables that are rich in vitamin C so that we have enough vitamin C for collagen formation. So we need vitamin D in order to get calcium from the GI tract. We need vitamin C in order to make collagen for the osteoid. And then we also obviously need enough calcium and phosphate for them to, form those hydroxyapatite crystals and calcify the bone. So all of those are important to have, strong, hard bones that properly calcify. So once your bone is made and it's calcified, it's not going to stay there inert your whole life. Your bone is living. Your bone undergoes metabolism all the time. As we said, it's really important for storing calcium and phosphate, but it would be it wouldn't be useful if your body stored calcium and phosphate in your bones, but you could never get it out, right? So we need to store it there, but we also need to be able to release it from the bones when we need it in the blood. And so in order to release that calcium and phosphate, if the blood needs it, if your body needs it elsewhere, that's where we have bone resorption happening. And this is going to be what the osteoclasts are really good at. So they're going to be destroying or resorbing the bone. This is also important for bone remodeling if we have to kind of, if the bone gets a little bit damaged and we have to repair it and then remodel it. So bone resorption happens when the bone matrix is destroyed by substances released from the osteoclast. And remember, we have these enzymes, these proteolytic enzymes, and so they're going to break down the proteins, they're going to break down the collagen, are released from the lysozymes within the osteoclasts. They're going to chemically digest the organic matrix components, so the organic things. So the collagen, the proteoglycans, and the glycoproteins are going to be chemically digested by those lysosomes. And that's going to be in that resorption lacuna. Remember, we said the osteoclasts are kind of spitting out that, you can think of it as acid, but it's really just proteolytic enzymes in order to dissolve the bone. And so we're dissolving the organic components of bone. But it's not actually going to hurt the calcium and phosphate ions. The calcium and phosphate are going to be dissolved. They're going to be broken apart by hydrochloric acid. But that hydrochloric acid is going to dissolve it and break it apart. So it's not calcified anymore, but that frees the calcium and phosphate ions in order to enter the blood. So it doesn't destroy the calcium and phosphate ions. It just breaks them down. So it breaks up that calcification and then frees those ions to enter the blood. And so when blood calcium levels are low, we want to go to the bone and take out that calcium that's been stored in the bone, and the osteoclasts can do this. So as we digest the bone, we digest the organic components, and then we dissolve the mineral components. That's going to let the calcium and phosphate ions enter the blood. And so this way, we can raise the calcium. And so the osteoblast and the osteoclast have to exist in balance. Remember, we talked about homeostasis, and we want to have everything kind of balanced around this set point. So we want to make sure that we don't have, either too much bone formation, where we have like lots of extra bone, or too much bone resorption, where our bones are, going to be really thin and brittle. And so hopefully we have this nice balance. So we have these strong bones that, are well remodeled, and we also have enough calcium in the blood. But there are a couple of different disorders that we can have relating to an imbalance in osteoclast and osteoblast function. And so this is called, one of them is called osteitis deformans, and it's characterized by excessive bone resorption. So first we have the osteoclast kind of going crazy and resorbing the bone, and then this is followed by excessive bone deposition. And so then we have more bone being deposited by the osteoblast. And so usually you have larger osteoclasts that resorb bone at a higher rate. And so then the osteoblasts kind of have to, rush to catch up. And the newly deposited bone is kind of poorly formed, right? They do a slipshod job. They don't really do a great job. And this can cause bone deformity and pain, and most commonly in the pelvis, the skull, the vertebrae, the femur, and the tibia. But just the take home of this is we want to make sure that the osteoblasts and the osteoclasts activity is well regulated, so that we don't have either too much formation or too much destruction of bone. And we're going to have some hormones that we'll talk about that are going to help regulate this. So regulating blood calcium levels is kind of a big section, and I want to talk about this. This is also the first time we're really going to be talking a lot about hormones. We mentioned vitamin D, and vitamin D is a vitamin, but it also acts as a hormone. And so we'll mention a little bit about hormones. And this is also one of the main homeostatic control mechanisms that we're going to learn for the skeletal system. And so a homeostatic control mechanism is where, remember back to chapter 1, we talked about it can be regulated by positive feedback or negative feedback, and it usually is going to be trying to keep the internal conditions stable. It's going to keep the body at a set point. And so we're going to be trying to keep the level of calcium in the blood at a set point. We don't want too much, we don't want not enough. So calcium is really important for a couple of things. It is essential for the initiation of muscle contraction. When we get to chapter 10, we'll talk about why calcium is so important and what it does in muscle contraction. It's also really important for the exocytosis of molecules from the cells, including neurons, so the neurotransmitters from the neurons. So any like our nervous system depends on calcium. It is important for stimulation of the heart by pacemaker cells. So our heartbeat and the regulation, our nodal cells, the heart rate and our heartbeat requires calcium. And calcium is required for like every step in blood clotting. So it's really important that we have calcium. And it's really important that we have the right amount of calcium because we don't want too much calcium either. If we have too much calcium, and especially if we have too much calcium and too much phosphate, either within the cells or in different areas, it can cause calcification where we don't want it to happen, right? So we really want the calcium and phosphate to come together and form hydroxyapatite in the bones, but not really in other places. So there's two primary hormones that regulate blood calcium. Calcitriol, which is the active form of vitamin D, like we said, that's a vitamin and a hormone, as well as parathyroid hormone. So what exactly is a hormone? Before we start talking about it, I want to back up. Remember and think about the different types of glands we had. So we had exocrine glands and endocrine glands. Exocrine glands release their products via a duct to the surface of the epithelial tissue. And endocrine glands were the ones we didn't talk about yet. So the endocrine glands do not have ducts, and they release their products into the blood. So endocrine glands release hormones into the bloodstream. And see, these hormones are usually going to be little, either proteins or steroids, and they're little chemical messengers. So think of them as a chemical messenger that goes through the blood, and it's going to go and it's going to bind to a target cell. And that target cell has a specific receptor for that hormone. And so it's a way that we can have a gland that sends out a signal, then it's going to go through the blood to regulate an effector somewhere far away. So two of these hormones, these chemical messengers that we'll talk about, are calcitriol, which is the active form of vitamin D, and parathyroid hormone. So this is a review. We talked a little bit about this already in chapter 6. I wanted to mention it twice because it's important. So this is the part that happened. This is happening in the skin. So first we have our UV light that converts the 7-dehydrocholesterol, which is that steroid precursor molecule, to vitamin D3. So vitamin D3, this is the inactive form of vitamin D3, and that's called cholecalciferol. This is released into the blood. We can also absorb our vitamin D from our diet. And if you think about milk, milk has a lot of calcium in it, but it's usually also fortified with vitamin D so that you have vitamin D in the milk that will help you absorb the calcium in the milk. So this cholecalciferol is then going to go into the blood, and it's going to circulate in the blood to the liver. The liver has special enzymes that can convert it to calcidiol in the liver. So this is like the second stage, and I think of di as 2. And this calcidiol, once again, is still inactive. And we have got all of this happening pretty much all the time. So this part right here, whenever you get sunlight hitting your skin, it's going to convert that 7-dehydrocholesterol into the cholecalciferol. And then the liver is pretty much all the time is going to be converting that cholecalciferol into calcidiol. And that calcidiol is still not active yet. So it still needs to have one more modification before it becomes the active form of vitamin D. And so this last modification happens in the kidney. And the kidney is going to convert the calcidiol into calcitriol. And so it's adding this other hydroxide group on the end. So it's going to be calcitriol. And I think this is the third step. Tri is the third step. And so this calcitriol is then going to be the active form of vitamin D3. So right here, this step where the kidney converts calcidiol into calcitriol, this is a regulated step. And that means this is where the body can say, do we need more vitamin D or less vitamin D? So this doesn't happen all the time. All of these are pretty much unregulated. They happen all the time. But this step right here is going to happen pretty slowly normally, but in the presence of another hormone, parathyroid hormone, it happens much faster. And so if parathyroid hormone is present, calcidiol is converted to calcitriol much more readily. And so we'll have a lot higher levels of active vitamin D3. So what is parathyroid hormone? So parathyroid hormone is a hormone secreted from the parathyroid gland. And it's secreted in response to a low blood calcium levels. So the parathyroid gland is going to sense that blood calcium levels are low. And then it's going to send a signal. And this chemical signal is parathyroid hormone. It's going to send a signal to these effectors. So these are the main effectors. And this signal is going to tell them to spare calcium or to try to get more calcium into the blood. So the first thing it does is it acts on the bone, and this is really why we're talking about it in this chapter. It's going to act synergistically with the calcitriol to increase the release of calcium from the bone into the blood by increasing the osteoclast activity. So if we increase the activity of the osteoclasts, they're going to be breaking down more bone and releasing more calcium into the blood. We're stealing the calcium from the bones and releasing it into the blood in order to increase the blood calcium levels. So parathyroid hormone, once again, is released in response to low blood calcium levels. And so we want to take the calcium from the bone and release it out into the blood in order to get those blood calcium levels back to their normal state, right? The bone is using the calcium a little bit to harden the bone, but really it's also using it to store it. And so we want to make sure if we need that extra calcium that we can release it into the blood. Parathyroid hormone is also going to work with calcitriol at the kidneys to stimulate the kidneys to excrete less calcium in the urine and increase the calcium reabsorption. So we're going to be reabsorbing calcium. We're taking calcium back. We don't want to urinate it out if we have low levels of calcium. We want to take it all back. And then finally, the small intestine, it's calcitriol by itself. So vitamin D3 by itself is going to increase absorption of calcium from the small intestine into the blood. Remember, this is the vitamin D that's in milk is going to be helpful to help us absorb the calcium in milk from the gut. So this is a really important picture. Make sure you write it out. Make sure you know the steps of this. So once again, whenever you see this little homeostatic control mechanism image here, that's going to be something we'll talk a lot about because it has to do with maintaining homeostasis, and any disruption in these homeostatic control mechanisms can cause disease. So the stimulus here is low blood calcium. And so when we have low blood calcium, the receptor and control center are the same thing. So sometimes they can be the same thing. And so the receptor is the parathyroid glands. Parathyroid glands are these little tiny, you actually have 4 little tiny parathyroid glands usually around. They're sitting on the back of the thyroid gland. And we'll talk more about exactly, look at some models in 169. But so they sit on the back of the thyroid glands and they secrete parathyroid hormone, right? So parathyroid gland secretes parathyroid hormone. That one's pretty easy to remember. And so this parathyroid hormone is then going to act as the chemical messenger. And so this is the chemical messenger, and it's going to act along with calcitriol. So the first thing it does is it's going to go to the kidneys, and it's going to increase the conversion of calcidiol into calcitriol, so that in the presence of parathyroid hormone, we have more calcitriol than we would normally have. And so that's going, and then these two are going to work together at the bone. So they're going to act synergistically to increase the activity of osteoclasts. So they're going to tell the osteoclast to break down more bone to release more calcium into the blood. They're going to act synergistically together at the kidneys to decrease the calcium excreted in the urine. So we're going to be saving more calcium. We're going to be reabsorbing calcium from the urine. And then finally, at the small intestine, calcitriol alone, this green one, is going to help increase absorption of calcium from the small intestine. So from whenever we're eating or drinking, from that milk that we drank. And so all of these things together should help to increase blood calcium levels again and restore blood calcium levels. And so once the blood calcium levels are no longer low, the body is going to stop secreting parathyroid hormone. And so that's like a negative feedback mechanism here, where so parathyroid hormone is going to be secreted when blood calcium is low, and then once the calcium levels get high again, the parathyroid glands say, oh, you know, the calcium levels are normal, and they stop secreting that parathyroid hormone so that we stay at this nice level. So I briefly want to mention a disease called rickets. And this is going to be a disease caused by vitamin D deficiency in childhood. And so now if anyone has, you know, I guess listened to the recent recommendations, I have young children, so they recommend if you are like just breastfeeding your children and you're not giving them supplemental formula or not very much supplemental formula, they want to give them a vitamin D supplement to make sure they have enough vitamin D. Especially since they're also recommending that, you know, under 6 months of age, especially, you keep them out of the sun as much because you don't want them to get sunburn. And And so that's going to decrease some of their, their own ability to produce vitamin D. So they want to make sure that kids are getting enough vitamin D in childhood. Formula is going to be fortified with vitamin D, so that's why they're not worried about the supplement as much if you're feeding formula. But so if they don't have enough vitamin D in childhood, they are going to have not enough calcification of the osteoid tissue. So we might not be able to absorb enough calcium from the bone. And so we have low blood calcium, and so this can cause hypocalcemia, right? That means low calcium in the blood. Tetany, which is cramps and twitches because calcium is really important for those muscle contraction, and disturbances in growth because we need calcium in order to properly calcify the osteoid and properly make those bones calcify. They can have a bow-legged appearance because the legs might not be as calcified and strong, and so they become a little bit more bendable. This can occur in some developing nations if they don't have enough vitamin D, and there's an increasing incidence in urban U.S. children, probably just having to do with less sunlight and more sun protection. So there's a good picture of this in your book also if you want to look at a picture of radiographs of rickets. So now this is everything that happened when we have low blood calcium. But remember that anytime we have a negative feedback mechanism, so we need to have a mechanism for our blood calcium, our low calcium to get higher, right, to increase. But then we also need a mechanism if we have too high calcium for that to decrease. So we don't want low or high blood calcium. We want it to stay right where at the set point. And so calcitonin is going to be another hormone that aids in regulating blood calcium levels. And this is something that's going to help us if our blood calcium levels get too high. And so it's not as significant as either PTH or calcitriol, but it is released from the thyroid gland. So not the parathyroid gland, but this bigger one. So in this picture here, these little brownish dots here on the back, these 4 of them are parathyroid glands, and then this tan-colored butterfly-shaped one, the rest of that's the thyroid gland. So this is the thyroid, and it's going to secrete this hormone called calcitonin. And calcitonin is going to be released in response to high blood calcium levels. So it's the opposite stimulus as parathyroid hormone. It can also be secreted in response to exercise, right? This inhibits the osteoclast activity. And so it's going to be most effective if the osteoclasts were already working. So if they weren't already working, inhibiting them doesn't do as much. But if they were already working, then we can stop them from working. So it's going to have the greatest effect during bone turnover when the osteoclasts are already busy and working, because then we can stop them. If the osteoclasts were kind of resting already and we tell them to stop, it doesn't do as much. So it's going to inhibit the osteoclast activity and stop the osteoclasts that were working. And it also stimulates the kidneys to increase the loss of calcium in the urine. So we're going to pee out that extra calcium. And these things together should reduce blood calcium levels. And so this is kind of the opposite. I don't have a great picture like I did for that, but remember it's kind of the opposite. So in this case, we would have the stimulus would be right here, high blood calcium levels. So the variable is blood calcium. The stimulus is an increase in the blood calcium. The receptor and control center, again, are going to be the thyroid gland. So the thyroid gland is going to sense this increase in blood calcium levels, and it's going to make a decision to do something, and it's going to send calcitonin, right? Calcitonin is that chemical messenger, that hormone. It's going to send calcitonin to the effectors, and the effectors are going to be the bone, where it inhibits osteoclast activity, as well as the kidneys, where it stimulates the increase in loss of calcium from the urine. And this is going to work in opposition or against calcitriol and parathyroid hormone. And both of these, so these work together in order to maintain that blood calcium level at its set point. All right, so I'm going to mention a little bit more here about the effects of aging, as well as some things about bone remodeling. And so there are 2 ways that aging affects bone. So aging is going to decrease the tensile strength of bone. And so remember that the tensile strength of bone is because of the organic components, so because of the collagen. right? And so as you age, your osteoblasts are making less protein, so less collagen, and so the bone gets a little bit less strong because there's less collagen in there. And relatively, since we're making less collagen, we're going to have more of the hydroxyapatite crystals, the inorganic material. And then, so the bones will become more brittle and susceptible to fracture. We also have bone loss of calcium and other minerals, and so even if we have a relatively more hydroxyapatite crystals, we still don't have as much as you did when you were younger, right? So in general, your bones are thinner and weaker. We might even have trouble ossifying some of the bones, and this can be called osteopenia. And so this is going to be kind of both. We're both losing organic components of bone, and we're losing the inorganic components, so we have less of both of them. Osteopenia is going to occur slightly in all people with age. So it's kind of, this is bone loss. We have less bone than normal. It begins around age 35 to 40. And this is when our osteoblast activity is going to gradually decline. But the osteoclasts kind of stay, they keep going. So before they were, together and they were both sort of balanced. But now our osteoblasts don't really work as hard, and the osteoclasts keep working harder, and so we're going to have a net loss in bone, and we're going to have a little bit more bone turnover. So especially the vertebrae, the jaw bones, and the epiphyses are going to lose large amounts of bone mass. And women lose more of their skeletal mass every decade than men, especially after menopause due to the lower levels of sex hormones. Osteoporosis is going to be like a severe form of osteopenia, where our reduced bone mass is going to actually compromise normal function. And this is going to occur in a significant percentage of older women especially, but also a smaller percentage of older men. And a lot of it has to do with reduced hormones with age, not just sex hormones, but all of our hormones. And in the endocrine system, we'll talk about how as you age, most of the levels of hormones are going to start decreasing. So vitamin D is going to decrease, growth hormone decreases, right? It's highest when you're actually growing, when you're a young child, and estrogen and testosterone will both decrease, especially after menopause in women. And all of these contribute to the reduction in bone mass. And so osteoporosis is clinically very important. It is going to be linked to age, right? So older in age, the onset of menopause in women. Smoking history and Caucasian race can also play a part, and people who have a smoking history or are Caucasian are more likely to have this. And then once again, postmenopausal women are at most risk because of those lowered amounts of sex hormones. So because we're losing bone mass and the bone is becoming more brittle, it is more susceptible to fracture. And so the wrist, the hip, and the vertebral column are some of the areas that we have very commonly fractured. The best treatment is prevention with diet and physical activity in young adults. So make sure that you eat lots of things that contain calcium and you stay active. If you are active, weight-bearing activity is actually going to put some stress on your bones, and that is good. It's like that stress tells your bones that they need to respond and get stronger. So if you exercise and you do weight-bearing activities, even just walking around is going to help make your bones get stronger. It will increase your bone mass so that when you start, when you get to menopause, then you have a lot of bone mass already. And so that hopefully once you start losing bone mass, it won't be as, if you start with less bone mass and then you start losing it, you'll, more quickly go towards osteoporosis. Whereas if you start with more bone mass, then you're at a better spot. There are some medical treatments that involve slowing the rate of bone loss or attempting to stimulate new bone growth. So talk to your doctor about those. Now, I mentioned that osteoporosis increases the risk of fracture. And what is a fracture? A fracture is a break in the bone. And there are lots of different types of fractures. And if you go into orthopedics, they're pretty cool. And there's lots of different types, and they're all named. And there's a whole big chart in your book right here that you don't need to memorize all of these. But I do want you to remember these 4 specifically that are in the slide. So the first one is a stress fracture. And this is what you might think of, like when I was younger, I kind of thought a fracture and a break were different, where a fracture was just like a stress fracture and a break was an actual break. But any break or crack in the bone is a fracture. A stress fracture is a thin break that's caused usually by increased physical activity, and there's no displacement. That means the bones, there's just like a slight crack in the bone, but they don't actually move. Displacement means the ends of the bones come apart. So there is no displacement. They stay together. There's just like a small crack in the bone. And this is too much increased physical activity. I said that increasing physical activity is good because it puts some stress on the bone and that helps the bone become stronger. And that's like adaptive remodeling. But if you do too much activity, and that's maladaptive remodeling, and that can actually cause these pathologic or these stress fractures. So that's like if you're training every day for a marathon and, you know, training really hard, you might get a stress fracture. So we want this moderate amount of physical activity. A pathologic fracture occurs in bone weakened by disease. So as we said before, osteoporosis is going to predispose us to these fractures. So if we have osteoporosis in the bone and it fractures, we could call it a pathologic fracture because the bone was weakened by osteoporosis. Pathologic fractures can also occur if you have some sort of bone cancer. That can also make the bones more prone to fracture. A simple fracture is a broken bone that does not penetrate the skin. It usually does. It has a displacement, or there may be a displacement. The ends of the bone come apart, but they don't penetrate the skin. Whereas a compound fracture is where the displacement is so big that a piece of bone actually juts out the skin. And this is a problem for a couple of reasons, because imagine that you have like fallen off something and you have a compound fracture and you're in the dirt and in the mud. Now you've got so much damage to the muscle and the underlying, like to the skin and the muscle, right? Because the bone has broken through the skin and the muscle, but also you're losing blood. And you have all this dirt and gravel and grass in the wound and in the bone, and so you have a lot higher chance of infection. So compound fractures are usually a lot more serious and they take longer to heal, and there's more chance for infection. So as we said, there's lots and lots of different terms for fractures. This one is the comminuted fractures here. This is the one where like the bone kind of explodes and we have lots of shards. It's really hard to fix. This here is the example of the compound fracture or open fracture where we have the bone sticking out of the skin, and that's going to be a lot more susceptible to infection. So fracture healing. I want to mention a little bit about fracture healing. If you have a simple fracture, this is a fracture that does not penetrate the skin, it'll probably take around 2 to 3 months to heal. But this is going to differ in different ages. So young children that have lots of growth hormone and things, they're going to bounce back a lot quicker. So their bones heal much faster. Whereas older adults that have much lower levels of those hormones, their osteoblasts might not be working as effectively, will take a lot longer to heal. And then compound fractures, as we said, there's usually a lot more damage to the tissues surrounding the bones, as well as you might have blood loss and you might have infection. So compound fractures usually take longer to heal than that. So this is similar to our wound healing, where we have 4 steps of fracture repair that are, we're going to kind of simplify it down and just talk in very simplistically about the 4 different steps of fracture repair. So if we break a bone, remember our bones have blood vessels. So they have lots of blood vessels in them and a really good blood supply. So if we break it, we're going to be breaking those blood vessels too. So a fracture hematoma is going to form. So a hematoma is just a blood clot. And so hema, that is like blood or red blood cells, and oma means like a mass. So this is a mass of red blood cells or a blood clot that has formed. And so usually this is from those torn blood vessels, within the bone and within the periosteum. And so here's the picture here. We have got the bone has broken, right? Thankfully, this break does not seem that bad. The ends of the bones are fairly well opposed. They're pretty close to each other. Maybe it's been reduced already. A doctor has put it back in place already. And so now we have this blood clot that's forming in here. And that's the first step here. Then next we have what's called a fibrocartilaginous callus that forms. And so the fracture hematoma is kind of reorganized into what we call a connective tissue procallus. So this is kind of before the callus starts. We have a lot of fibroblasts coming in, right? So these fibroblasts, what do they produce, right? They produce the fibers, and they produce collagen fibers. And then we're going to have some chondroblasts in there that are going to help produce some dense regular connective tissue, and it's a fibrocartilaginous callus. Remember that fibrocartilage has lots of collagen fibers in it. And so this procallus becomes a soft fibrocartilaginous callus. And so here we've got this fibrocartilage callus that's here, and it's got lots of collagen in it, this soft callus. At this point, it's going to be trying to connect the ends of the bone and trying to get this a little bit more stable. The next part is we're going to convert this fibrocartilaginous or soft callus into a hard or bony callus. And this is where we have osteoblasts are going to be next to the callus produce trabeculae. So this is like those trabeculae, the spicules of spongy bone. And this is going to eventually replace that soft callus. And it's going to form a hard or bony callus. And usually this is going to continue to grow and thicken, and it's going to kind of come out a little bit further than the bone. And so you usually have a little bump on the edges. And then finally, the bone is going to be remodeled. So as you can see, we kind of have this immature sort of woven bone here. And we'll talk a little bit more about that in the next chapter. And some areas of spongy bone where we should have compact bone. So eventually we're going to have some remodeling happen. Also, right, we need to have a medullary cavity eventually. And so the final phase is going to be bone remodeling. So we have osteoclasts coming in to remove the excess bone material. The compact bone is going to replace that primary or woven bone, and that usually does leave a slight thickening on the bone here. So other things that I wanted to mention clinically about how this happens is that, as you can imagine, the closer the ends of the bone are together, the easier it is for all of this to happen. If the bone ends were really far away, you'd have to make a lot of bone to try to connect them, and it wouldn't work nearly as well. So we're going to try to make sure the ends of the fracture are opposed, like that they're right near where they need to be, that there's really no space that needs to be covered. And then the other thing is movement. So if the bone is moving like this all the time, it's going to be breaking down this callus. So breaking down both the fibrocartilaginous callus as well as the bony callus. So we need to make sure that the bone is immobilized and it's stable. Any movement is going to make it take much longer to heal. So we want to make sure, so you can use a cast to do this to immobilize it. You can use an internal fixator. You can use an external fixator. Lots of different ways, but we want to make sure that the bone is well opposed and that it's not moving. All right, that's it for this chapter, not this chapter, but this lecture. So next week, we're going to move on to talking about bone and cartilage growth and how it's formed and how you grow during your lifetime.